Welcome to the Parenting in a New Context podcast series. We're really excited to have you here and to share these discussions. I do want to make a quick programming note before we get started. The discussion in this episode was recorded in December 2019, and of course, a lot has changed in our world since then. In particular, COVID-19 pandemic has fundamentally reshaped day-to-day life around the globe. The recent police killings of George Floyd and other Black Americans has sparked widespread demonstration and renewed focus on racial equity, on police violence, structural racism, and on historical trauma. So you're going to probably notice instances in this discussion where timely examples that are relevant to our current moment are absent. But we think the ideas and the principles discussed are more relevant than ever, as more responsibility is placed on the shoulders of parents, especially with social distancing and school closures. It's even more important than ever that we as a society look closer and work harder to change our systems and structures to be more equitable for everyone. And that really is at the heart of these conversations. So thank you for listening. And now on to the show. Welcome to episode 1 of the series, Parenting in a New Context, Strategies for Practitioners Who Support Refugee and Immigrant Caregivers. It's a podcast series made for and by mental health practitioners, and over the next 4 episodes, we'll be highlighting some important topics that are relevant to working with refugee and immigrant families and caregivers. We're really hoping that listeners will walk away with a better understanding of these topics, as well as some concrete ideas for how you can improve your quality of care. The series is a collaboration between the Refugee Trauma and Resilience Center at Boston Children's Hospitals, the Center for Resilient Families at the University of Minnesota, and the National Child Traumatic Stress Network. I'm Trevor Born with the Center for Resilient Families, and I'll be your host for this series. And today I'm really excited to be joined by 2 psychologists from the Refugee Trauma and Resilience Center team, Mulder and Jeff Winer, to discuss the foundational tenets of culturally responsive care. Thank you so much, Luna and Jeff, for joining me today.
Thank you.
Thank you for having us.
Now, a lot of what we're going to cover in this series will focus on the importance of considering culture when tailoring care to the people you serve. So, off the bat, what exactly do you mean when you say culture?
Yeah, it's a great question, Trevor. Culture is one of those concepts that is commonly discussed, but often rarely defined. So our group thinks of culture as the lived, integrated, and inherited patterns of social and behavioral norms, beliefs, and customs of a group of people. It's both the attitudes and behaviors. It's directly observable and incredibly nuanced. So, for example, observable aspects of culture include things like the language you speak, the food you like to eat, the clothing you wear, the music you enjoy, or the religious ceremonies you participate in. Less observable aspects or more subtle aspects of culture include things like beliefs, values, attitudes, and how they guide our behaviors, thoughts, and emotions. Culture influences how individuals see the world, how others interact with them, and then how those pieces unfold over time. Culture is the style in which people engage with the human experience. It's essentially the sunglasses we wear as we navigate the brightness of life. And now it's important to consider that if someone has grown up in a very homogeneous environment where many of the people are of a very similar background, they may not be aware that their own beliefs, attitudes, and essentially entire way of life are in fact a culture. We often, and somewhat ironically, don't become aware of our own culture until we interact with individuals of other cultures or are exposed to other cultural contexts. Culture is the air that we breathe, and we only become aware of it when we start breathing different air. So to provide a little vignette, this is adapted from the late David Foster Wallace. Imagine there are 2 young fish swimming along, and they happen to meet an older fish swimming the other way. The older fish nods and says, "Morning, boys. How's the water?" The 2 young fish keep swimming on for a bit, and eventually one of them looks over at the other and says, "Wait, what is water?" This is water. Culture is the water that we live in.
Yeah, I've always loved that analogy because, the difference between living in water and living in air is so significant. It's one of the biggest differences you could possibly have. And, if you've only ever interacted with beings that live in the water,
yes, exactly.
You're going to have a really hard time understanding what the air-dwelling beings, why they do what they do, and it'll make no sense to you. So why is it that this cultural lens is so important when it comes to serving refugee and immigrant families?
Culture is very important to consider because all aspects of life is informed by culture. Much of our field, the field of psychology, has been informed by Western views and values. And some of these may be in line with the experiences and values of refugee and immigrant communities, while some may not. Culture also informs how trauma and mental illness is discussed, understood. I'm originally from Bhutan, which is a small country in South Asia, where the majority of the Hindu population was ethnically cleansed from the country in the early 1990s. In the Hindu religion, suffering and adversity is explained through a belief system called karma, which is the result of sin committed in a past life. Spiritual and religious explanations for suffering and symptoms is very common in many cultures. Diagnostic constructs that we have, such as depression or anxiety, does not exist in many other languages. It is more common to express mental health symptoms and emotional pain through somatic complaints, so through bodily aches and pains, things like headaches and stomach aches and backaches. One idea that is commonly discussed is the difference between individualistic culture and collectivistic culture. Generally speaking, within individualistic cultures, individual needs may take priority over broader community or family needs. Within collectivistic cultures, however, community and family needs may take more of a priority than individual needs. So what does that actually mean? I'll provide a concrete example. In Bhutanese Nepali culture, individuals are often referred not by their first name, but by their relationship to others in their family and community. So for me, if somebody in Boston were to ask me what my name was, I would most likely say my first name, which is Luna. Whereas if I was in my family's village in Nepal and somebody asked me who I was, I would most likely say my birth order and my family's last name. So a direct translation of that would be Jeti Achajaka family, which means the oldest daughter from the Acharya family. Every relationship and birth order has a name associated with it in the Nepali language. In that context, who I am, the foundation of my identity, is defined not by me and my individual first name, but by my family and community relationships. So in regards to health, and particularly mental health, our experience has been that across all refugee and immigrant communities, families want their children to be healthy, but what healthy means is culturally constructed. Diagnostic constructs such as depression, anxiety, post-traumatic stress disorder, the meaning-making of these symptoms, and associated help-seeking behaviors are again all culturally defined and therefore require culturally responsive strategies to address effectively. So how we explain mental illness and our role, the words and framing that we use, and aligning with refugees and immigrants and their understanding of what the presenting problem is, how they understand the symptoms, and how they might go about addressing it becomes an extremely important part of providing culturally responsive care.
Now, two terms I see a lot in the work of the center and in both of your work are cultural humility and cultural competency. So what do these mean and how are they different and why are they important?
Yeah, so cultural competency and cultural humility are essentially two pedagogies, meaning they're teaching frameworks for how to effectively navigate cross-cultural work. And while some folks take a strong stance for one or the other, we've often found that the integration of both strategies, although leaning more on the cultural humility side, can lead to the most culturally responsive care with refugee and immigrant communities. So to define them, cultural competency are essentially things to say and do or things to not say and not do with individuals of a particular cultural background. Cultural competency often takes the initial form of foundational, factual information and learning, so sort of crystallized knowledge that you're trying to obtain. This can include things like the geographical location of someone's country of origin, the common languages that are spoken there, and when working with refugee communities, the key historical events that led to forced migration. Importantly, this is the type of information that a provider could actually learn before the first session with a client or caregiver. taking just a few minutes to do some reading about a new client's cultural background can be incredibly important because it communicates some level of awareness and highlights the potential for further learning. In a clinical encounter, if one communicates a true lack of foundational knowledge about someone else's cultural background and way of being, it would only make sense that the parent sitting on the other side of the room may worry about that individual's competency and ability to provide tangible help. So, for example, if I was working with a Bhutanese refugee, it would probably be important for me to know that, as someone not from a Bhutanese background, that Bhutan is a mountainous country north of India, and that huge populations of Bhutanese citizens were ethnically cleansed, as Luna alluded to, from the country and lived for many years in refugee camps in Nepal, some adults for as many as 20 years. A few basic facts can open the door for further effective culturally responsive care.
Which I guess then begs the question, is it even possible to be fully competent in every culture?
Exactly. And that's the common critique, justifiably so, of cultural competency. Are we trying to just learn a lot of facts and figures about cultures? Is that really what brings people into this work and what leads to effective care? The answer is almost certainly no. And it's true. We can't become culturally competent in all cultures. And often, again, speaking for I as well, I'm not sure if I'm culturally competent in my own culture, whatever that means. And this is where cultural competency falls short. It's a framework that can unintentionally create a false sense of expertise and confidence, which can unfortunately lead to overly reductionistic thinking and decision-making and actually be harmful and perpetuate non-culture responsive practices. So not all people from Bhutan or Boston are the same, and it's ineffective to make broad assumptions and then associated clinical or programmatic decision-making based on very sort of narrowly defined expectations. And so this is where cultural humility comes in, which was a framework developed in 1998, so now over 20 years old, by two physicians, Melanie Turvalon and Jean-Marie Garcia, which is really a stance or a way of being around people that's focused at its heart on social equity. And cultural humility is a stance of being open and curious and empathic as we try to build equitable systems together. Cultural humility in that original 1998 framing is really based on three tenets, which I'll highlight now. The first is lifelong learning and critical self-reflection. Often in cross-cultural, multicultural psychology work, we focus our lens on other people and other communities. But the importance here is we need to first focus the lens on ourselves, our own positionality, our own socio and cultural biases and blindfolds. And from that stance, we're able to most effectively learn about others. The second piece is about recognizing and challenging power imbalances, particularly those inherent in dyadic relationships. So doctor-patient relationships, client-clinician relationships, student-teacher relationships. These are all dyadic power structures where one person often has a lot more institutional or social power. However, their job is focused on supporting the other person. So how do we do that in an equitable way that really sort of moves things forward in a way that's effective? And then the third, which is often the sort of the slowest to come about and can be the most difficult, and often it's the one that individual providers are the most wary of, is institutional accountability. So we can do all of this work and be amazing clinicians. However, we also need to push institutions to model, support, and fund this work at all levels of the institution organization. So as providers learn about these ideas or hear about these concepts, people are often eager to communicate with others some of these goal and value-based stances. How do I get people to know that I'm in this work together or I'm trying to be culturally responsive? We generally recommend that rather than saying something like, I am a culturally competent clinician, whether that's describing yourself on your website or communicating with potential clients or organizations, we'd recommend taking a stance of saying something like, I strive to practice culturally responsive care, which is a more value-based stance. It's also more accurate and it's also more attainable.
I see. So cultural competency has more to do with understanding some specific facts and ideas about a person's specific culture, building some baseline competence. But it's unrealistic to think you could ever become like totally competent in someone else's culture. So cultural humility is a way of being, or a stance, as you say, that emphasizes learning and acknowledging power dynamics and promoting equity. So what does that look like in practice?
Okay, so imagine the elevator at the clinic where you work is broken. As an able-bodied clinician, the water you swim in is essentially the privilege to select options like, oh, I'll just take the stairs today. Then imagine if you are a refugee caregiver who is a survivor of torture and experiences chronic pain. The privilege of taking the stairs may not be an easy option. And the clinician's annoyance at someone being late for an appointment because they had to take the stairs communicates a lack of respect and awareness that can be incredibly detrimental for individual clinical services and building effective interventions. If we were trying to provide some culture responsive scaffolding to navigate this type of situation, the 3 ways I would maybe recommend would be, first, for a clinician to acknowledge their lack of awareness and relative power in how they navigated the situation, essentially acknowledging they had the privilege to not think about that and making a commitment to continued critical self-reflection. Second is to try to seek equity within the dyad in that moment. And so one strategy could be trying to figure out, okay, how are we going to provide services in an effective way? Should we meet in the lobby, or should we meet at your home, or meet in an office on the first floor? How can I best provide these services in a way that feels affirming, equitable? And third is really demanding institutional accountability rather than that clinician simply waiting until the elevator gets fixed, escalating that issue in the service of providing better care.
Or let's say a clinician is working with a refugee family that has come from a refugee camp where food was limited and rationed. In the refugee camps in Nepal, within the first couple of years after coming to the camps, many children actually ended up dying from starvation due to lack of food. And as the parents are talking to the clinician about their daily routines in the U.S. after resettlement, the parents talk to the clinician about how their son comes home from school and opens the fridge to drink a bottle of soda while munching on his favorite chips for the rest of the day, and continues to eat chips and soda through dinner as well. The parents don't seem concerned about their son's eating habits, and if anything, they seem delighted and proud that their son is able to go into the kitchen and get whatever food he wants to eat. Initially, the clinician reacts with judgment and concern about their son's eating habits. A clinician may then provide information on nutrition, which is important, but if the clinician does this without an empathic understanding of how the family spent most of their lives with limited access to food and without an awareness of the clinician's own privilege of growing up in a food-abundant culture, an intervention of providing information on nutrition may not be as well received by the family. Ideally, the clinician should empathically acknowledge the family's history while also holding an awareness of his or her own privilege in terms of access to food before providing information on nutrition to the family.
Oh, that's such a fascinating example. And it's kind of a good segue because you've now touched on a couple situations that are sort of specific to the experience of immigrant and refugee families. Can you give a couple more examples of the sort of stressors that are unique to that situation that providers should be aware of and how they might respond?
Sure. So in our research and clinical experience working with refugee and immigrant families, we have found that most, if not all, face common core stressors during the migration journey and after resettlement. These 4 core stressors include trauma, acculturation, resettlement, and isolation. One stressor common to refugee and immigrant families in particular is the acculturation gap that can emerge between caregivers and their children. The acculturation gap refers to a changing set of values and behaviors between a child and a caregiver, often driven by the fact that kids tend to acculturate and adapt much faster than adults. This can lead to a change in power dynamics between family members, where caregivers can feel disempowered and disrespected. Many refugees also feel very isolated after resettlement, so the trauma that they have experienced combined with stressors after resettlement can contribute to mental health problems. Many do not receive adequate mental health services because of the barriers to care, including stigma, the primacy of resettlement stressors like finding housing and employment, meeting basic needs like food and things like that. And then, of course, on top of all of this, there's often the lack of providers who speak their language and understand their culture.
And how might you navigate that?
Well, one thing that we talk a lot about at our center is we talk a lot about working closely with cultural brokers. Cultural brokers are members of the refugee and immigrant community who work as part of an intervention team by providing both linguistic interpretation and cultural knowledge to facilitate effective care.
And I know your team does a lot of work on this. Do you have any tools you can recommend?
Yeah, I think the strategy is how do we continue to scaffold providers doing this work above and beyond just talking about it. So two tools to highlight. One is our Refugee and Immigrant Core Stressor Assessment tool, which we initially developed through funds from the NCTSN. This is an interactive psychosocial assessment tool focused on the 4 core stressors that Luna alluded to earlier: trauma, resettlement, isolation, and acculturation. And it helps guide assessment and treatment planning with refugee and immigrant families. Another resource to highlight is one that I helped develop, which is a website called multiculturalpsychology.com, which provides some free resources for clinical and educational interventions focused on self-reflection, intervention, and then culture responsive practice.
Excellent. Well, we'll make sure to get links to those in the show notes. And I just want to thank you both again, Luna and Jeff, for your time and for highlighting these really bedrock ideas of culturally responsive care. They really set the table for what we'll be getting into in the coming episodes. And in episode 2, specifically, we're going to discuss how culture and the experience of joining a new culture shapes parenting norms, practices, and values, which providers should be considerate of. So be sure to check that out, and we'll have links in the show notes for everything we've talked about today. Thank you for listening, and thank you again for being here.
Thank you.
Thanks.